Hello, we continue with our musculoskeletal ultrasonography course, and we're going to talk about why ultrasound in orthopedics. Material available on our website and on our YouTube channel. When we start studying ultrasonography, a lot of questions come to mind. What is this? Why should I do it? Why? And how can I implement it? So, what is musculoskeletal ultrasound? Well, basically, it's a tool just like any other that we use in our practice, like a scalpel or any other diagnostic or therapeutic tool. And in general, it's going to make our professional work in musculoskeletal medicine easier. When we ask ourselves, what for? Well, we wonder why do it? And really, the what for was the answer to many problems that we had. When I started the project in 2010, I had 3 questions I wanted to answer. First, what was the accuracy of the procedures we were performing in the outpatient clinic? Second, we had some difficulties with our students learning anatomy in the department, and we wanted to see what other options there were to improve this learning. And the third problem was the bad reputation that ultrasound had up until then. So, for the first question, when we saw patients with high body mass index or with normal body mass index, we would insert a needle like in this example and say, we're in the right spot. The needle reached where it was supposed to. It's the same if I place it pointing down here, towards the lower part, as if I pointed upwards. It could be subacromial or intra-articular. So, really, we didn't have an answer, even though at that time we performed 1,029 injections in the department without ultrasound guidance. We'll show the current numbers later. Back then, the key thing we were taught was to use volume. Use enough volume because something would reach the target area. However, we started to wonder, at what cost? What about toxicity? We're applying it at the site, but what is the patient's satisfaction, and what are the real outcomes? The overall results. So we started reviewing the literature, and we had our residents and students do this exercise. We told them, you're going to inject 1 centimeter into the PS anserinus. What percentage of accuracy do you commit to achieving? Obviously, in this exercise, without having any bibliographic references, the student or resident would respond with very high percentages that probably weren't realistic. So when we reviewed the data, we showed them that this is a cadaveric study where that 1 centimeter of contrast medium or dye was injected into the PS anserinus and only reached the target in 17% of cases. Whereas with ultrasound guidance, it reached the target in 92% of cases. So let's look at what the literature says. And when we review the literature today, there is enough evidence that almost all procedures improve in accuracy when performed with ultrasound guidance. There's no doubt in some cases, for example, the acromioclavicular joint, where there's a clear advantage with ultrasound compared to without it. There are some areas, like the elbow, where the literature isn't as solid, but we'll also cover that in other talks. We would need to take a closer look at exactly what is being evaluated in these studies. In sports medicine in general, nowadays I also want to pose a question. Who does a hip injection without ultrasound? Extending that to other areas, if you already know how to use ultrasound, then why would you really do it without it? There's a lot of evidence telling you to use it. So if we have the evidence, I think we should use it. And what about the patients? How do they feel? We're also looking for, and there are actually studies like this one that show, for example, that when ultrasound is used, not only is it more effective, but there's also less pain. This translates into quality and benefits for our care and for the patient's perception. Less pain. Besides that approach, it's worth continuing. So nowadays, if we carefully review the literature, we'll find evidence that allows us to say that there is more accuracy with ultrasound than without it in practically all segments, and the percentage is significant both in the lower and upper limbs. With this, we practically resolved one of the concerns. However, our students' learning led us to question whether it was worth it to continue with traditional methods. And finally, we implemented a course on clinical and sonographic musculoskeletal morphology for our students starting from the first semester. And what we intended was for these diagrammed images to be interpreted from the very beginning, easily by students and practitioners, and we truly believe that today this is possible. We also wanted to make sure this wasn't just our perception, so we checked the literature to see if there was anything supporting this belief. When we looked into whether it was worth implementing, we found that nowadays reputable universities have documented and written about the clear advantages in learning anatomy and physical examination. Terms like palpating with your eyes have even been coined, because ultrasound allows us to expand our ability to perform physical examinations. Universities like Oakland truly believe that it should be incorporated into educational programs, similar to other universities like Pittsburgh, where they have actually found a significant improvement in the learning of anatomy and in physical examination. At Harvard, they go even further, and students consistently perceive that the use of ultrasound is valuable and allows them to improve their learning ability. So, with evidence from the literature, we have also implemented it, starting from the basic courses, from the first semesters all the way to the more advanced ones. And I always bring up this beautiful study because it's an extrapolation. Even though it's a cardiology study, what I want to show here is the power of ultrasound when we use it as a routine tool. They took some cardiologists with their stethoscopes and 20 years of experience and put them up against these students who hadn't finished their degree yet, giving the students 18 hours of ultrasound training without having completed their studies. Professors with 20 years, board certified, are professors with 20 years of experience and their stethoscopes, and they were put to diagnose complex cardiovascular, pulmonary, and cardiac pathologies. And the results, well, speak for themselves. Diagnosis rate among students, 75%. Professors, 49%. At some point, this will be extrapolated to musculoskeletal cases. We have no doubt, given the evidence available today. So, another very beautiful article also appears in JAMA, where they say, we traditionally learn medicine with 4 pillars: inspection, palpation, percussion, and auscultation. But today, we must add a 5th element to this arsenal, which is sonography. Nowadays, schools need to implement this because we can't just rely on palpation and maybe auscultation. In orthopedics, obviously, this is a tool that is beyond question. It's something that really should be used. So as a complement to traditional teaching, there's really no doubt about it. However, I also think that in semiology there's a huge space for this, as well as in research, because signs that have always been very subjective, like the piano key sign on a clavicle, where you always just estimate and your brain tells you it's 1 centimeter, 2 centimeters, grade 1, grade 2, grade 3. It would be much better if we could look at it with this ruler and measure in millimeters, and even make signs like the sulcus more objective, or it would be much more practical for signs like the drawer test, the step off, the Petrie hammer, measuring them with ultrasound and saying, for example, that there is a tibial translation of so many millimeters, and classifying that as grade 1, 2, or 3, and not just relying on my finger or my own perception. So there's no doubt that, in daily practice, the literature also supports us using it routinely. In our practice, we use it all the time in the office, because in more than 50% of cases, we change the diagnosis when we use ultrasound, and even within a segment, we sometimes change the location of the diagnosis. This is something that, once you start doing it routinely, you'll realize that this percentage is real, and it's supported by the literature. When we have a patient, we are convinced that we have improved clinical practice, reducing tests and visits, not just because the literature says so, but because when we examine our patient, we immediately do an ultrasound for certain segments. It's very quick. The patient sees it, feels much more satisfied, and then we take them to a room and perform a procedure, an injection, whatever it may be, or an ultrasound. In the end, this patient will have fewer visits and tests. Thank you, and they're going to save a lot of time and feel more satisfied. And there is also literature showing that this reduces costs in the healthcare system. Listing the advantages. Everything so far are advantages. Besides being accessible, we can carry it in our pocket with ultrasound devices. It can be immediately correlated with the physical exam, or perform it bilaterally and dynamically. It can be repeated as many times as I need without any radiation. What is it used for? It's important to know it's a good diagnostic tool, but you need to know when it is and isn't appropriate, its limitations, and that's we'll learn as we go. For interventional procedures, we have no doubts for collections, diagnosing tendinitis, and for monitoring inflammatory diseases. We believe there are more advantages than disadvantages, but the downsides do exist. There's the need for an ultrasound machine, but nowadays these are devices you can get at a very low cost, and we literally have them in our pockets. As for the learning curve, yes, but not really. The learning curve is about the same. It's the same curve as learning MRI. The thing is, if you don't see something on an MRI, don't go looking for it on an ultrasound. You need to know how to read MRIs in order to properly interpret an ultrasound. Regarding examination time, studies show that if you only need to scan one segment, you can define in 2 or 3 minutes. Supported. Relying on the examiner is a paradigm we must eliminate. I can't rely on others. I need to do it myself. To reduce inter-observer variability, we must improve through self-learning. If I depend on the radiologist, who isn't examining the patient, nor a clinician or surgeon, then obviously, we're going to reduce the effectiveness and benefits of this. I think the bad reputation, as of today, needs to be reevaluated. Did we think this was enough? Well, actually, no. The bad reputation actually comes from those difficulties that sometimes existed. And we wanted to look at why it has a bad reputation. And it turns out that those who taught me, my professors, probably learned with this. These were the first ultrasound machines back in 1951. Patients were submerged in bathtubs filled with water and plates. The equipment took up half the room, with images not even shown here. But nowadays, look at how things have changed. It's the same story as with computers and technology. Today, we have high-quality images in our pockets. A pocket-sized probe versus a high-end machine. It is operator dependent. But if you know how to read this, you know where the superficial flexor is, the deep flexor, and where you'll see the median nerve. And here, you'll be able to see it in this segment of the forearm. So the bad reputation is just about learning something new. And this is like learning another language. So in this photo where it says, some people need glasses to read, others need a book. Ian Hept and Brill know the Humpty lesson, the Ender and Buck. It's like I say, learning ultrasound is like this. It's like learning another language. But for us, the orthopedists who are used to seeing this, who know the anatomy, who are familiar with the surgical anatomy of all the structures, well, we already have the grammar. So we have an advantage when it comes to learning ultrasound. What do we need to learn? Well, basic concepts about how sound behaves, about the equipment, how to handle a grayscale, and understanding what artifacts are. We also have this available in our conferences, and it's just a matter of studying it. So this part would be the grammar of our learning, using the analogy of a new language, which is reading sound. That's the interpretation I give it. When we thought we had already solved all these problems or questions, more questions than problems, it turned out that in my country, in Colombia, it still wasn't enough because the regulations apparently didn't allow you to do this unless you were a radiologist. So we said, but how can that be? Let's take a closer look at what it actually says. And is it really the case? Shouldn't technology be used nowadays? Shouldn't I be using these technologies in my daily practice? If I have it at hand, is the law really telling me not to use it just because it's the law? We don't just take things at face value. So we also decided to look into what the law actually says. And in Colombian law, it's very clearly regulated that if I, as a healthcare professional, have certified training from a university, then I can perform ultrasounds. So we paved the way with this, always respecting the rules of our institutions, our workplaces, and in general, the laws of the country. But I believe that nowadays there is evidence that we can do it. So my final message is that this really isn't something easy, although I think it becomes much easier once you learn a few simple things. Thank you. It just becomes routine, so it's better for all of us to learn it, and that's what I'm trying to do. That's why these videos are free, and for anyone interested in learning, the university or the clinic can help facilitate that learning, because in the end, we all have to get on board with this. Nowadays, when orthobiology, injectable therapies, and regenerative treatments are just beginning to reach their potential for use, they should undoubtedly be performed with ultrasound. So we have to get on board with this. Don't forget that this is our stethoscope. The fifth element, sonography, is what we should be using. Thank you very much.